Well, welcome everybody. I'm going to continue letting folks in from the waiting room as they join. I'm Ruth Schwendinger, and I get to work with Prevention Network. I'm based out of Lansing. We're a statewide nonprofit doing technical assistance, coalition support, supporting with funding and training, and really doing what we can to acknowledge and support those boots on the ground, those people doing direct service. We work aligned with, but outside MDHHS, and we work closely with our PIHP, our coordinators around the state. So I really appreciate the time that you're taking today. Really quickly, I'm going to introduce Olivia Stewart, who is our presenter for today. We are recording. Olivia has asked us to use the chat function in Zoom. And so if you have questions or comments throughout, that's going to be our primary way of interacting. There will have a time for questions at the end, but Olivia has graciously created this presentation for us, and there is a lot of information that we discussed and we would love to get to you. So Olivia Stewart is a research assistant with Carnivale Associates. Olivia serves as a subject matter expert with SAMHSA's Central East Prevention Technology Transfer Center and the Strategic Prevention Technical Assistance Center, and has presented at CADCA, the National Prevention Network Conference, and other national conferences. And with that, Olivia, it's all yours.
Thanks, Ruth. Hi, everyone. So give me just a second here to get my PowerPoint up for all of you. So you should be seeing my slides. Is that correct?
Yes, we can see just your slides.
Okay, awesome. Okay, so, I want to thank everyone for joining us today for this webinar that we're doing on addressing challenges in collecting and using data in substance use prevention. So, like Ruth said, my name is Olivia Stewart. I'm a research assistant with Carnivale Associates, and I'm going to be taking you through our slides today as we talk a lot about data and prevention, the ways that we can use it, some of the challenges we might run into, and just the importance of utilizing data equity. So as I'm kind of introducing myself and my company on the next slide, I would love to see from you in the chat, where you're from, what your role is, maybe your level of experience or knowledge about data and prevention would be helpful. So please go ahead and use that chat. And also, if you have any questions throughout the presentation, please drop them in the chat. I do have multiple screens, so you might see me going back and forth, but I have the chat up here. So if I do see the question, I would like to take the time to answer it. Otherwise, I believe Ruth is monitoring the chat so that we can kind of pull together some questions at the end for a Q&A. We should definitely have time for that. So just a little bit about our company. So Carnivale Associates is a woman-owned small business in the DC area. And so we provide consulting services, research and evaluation, and training and technical assistance among some of the many other things that you see here. My team specifically, we do training and technical assistance for various governments, nonprofits, and coalitions on a pretty wide range of topics across behavioral health, prevention, the criminal justice system, and lots of other things. I've been at Carnivale Associates for about a year and a half now, and in that time, I've done, at this point, dozens of webinars, TTA engagements, conference presentations, lots of written products on a pretty wide range of topics, including data collection, cultural humility, different elements of strategic planning, identifying emerging substance use trends and evidence-based programs, lots of different things. But my background's in social work. I'm actually a licensed master social worker in the state of Virginia. And so before Carnivale, I spent a couple years actually doing qualitative research with young adults in the criminal legal system and young adults aging out of the foster care system. So I do have a real strong interest in data, how it can be used to advance health equity and kind of expand the reach of services, especially for multiply marginalized people. So I'm really excited to be here with all of you today to talk about data and how we can use it in prevention. So for all of our webinars, we kind of like to ground ourselves with some learning objectives, right? So our first learning objective is going to be how we're going to explain how data supports prevention planning and programming. We'll then talk a little bit about, what data is and how it's important to strategic planning. Second learning objective is
If
to,
you have any questions, let me know. I know it's blurry.
oh, thank you. Yeah, if you could stay muted if possible, that would be awesome. Thank you. Our second learning objective is to recognize the different types of data that are relevant to prevention and identify some data sources and data collection methods. And then we'll spend some time on our third learning objective talking about some of the common barriers that we see in data collection and a couple of strategies to try and overcome some of those challenges. And then finally, we'll talk about the importance of ethics in data and ways to promote data equity. And as I've been looking through the chat, I've seen a couple different social workers, so shout out social workers. And thank you all so much for writing about your experience in the chat. So let's go and get started with our first learning objective, which is going to be about the importance of using data in prevention. So we know that the implementation of prevention is really guided by evidence-based policies, programs, and strategies, our EBPs, our environmental change strategies, things like that. And the evidence-based strategies that we used are really only evidence-based because we actually have the data to back that up through evaluations. So using data is super, super important to prevention. It's how we're measuring our success. It's like how we measure our impact in the field. But before we even get to addressing the problem, data is what helps us identify what the problems are. So it tells us, how often problems are occurring, where they're occurring, to whom, if there's any disparities between groups, and really importantly, why the problems are occurring. And so part of what we do in prevention is take data, which people think is kind of just, numbers and statistics, and we really take the time to personalize it because I really want to emphasize the point that every data point in prevention represents a real person at the end of the day. When we get data on the number of overdoses in the county over the course of the year, those numbers represent real people that died. And then conversely, if we see the overdose rate has dropped by 5–10%, that represents real people who are also still here with us. So the work that we do to really advance data collection and reporting in like an ethical and equitable way can really help us take the time to tell those stories. So very high level, what do we mean by data? Data is really any piece of information that can be used for some purpose. And if that sounds really broad, that's because it is, because truly almost anything can be considered data. We'll talk about what that means in sort of different communities and different contexts a little bit later on. But usually data is collected to answer a question that you have. So how many participants completed our program? What was the rate of binge alcohol use in our community last year? So data can be classified in a lot of different ways from many different perspectives, but we're not going to dive into all of that today. The most important piece I just want to remind everyone here of is that data can be quantitative, which has to do with numbers. This is data that's, measurable, countable, fixed, and objective. Or data can be qualitative. And so qualitative data uses words, not numbers. It's something that's observed, but not really able to be measured in the same way that quantitative data is. So qualitative data really describes how and why people feel, experience, or perceive things. And it's entirely subjective. The whole point of qualitative data is that it's people expressing their own subjective experience. And so as researchers and people who use data in prevention, we kind of use analysis to draw out those common themes. So you can use both or either or one, depending on what your questions are and what you're trying to measure, but both are really, really valuable to us in prevention. We can kind of see the ways that data really underpins this concept of delivering evidence-based prevention through the strategic prevention framework or the SPIF. I assume everyone here is probably pretty familiar with the SPIF, but super, super briefly, this is SAMHSA's planning model and process for prevention that has each of these 5 steps that you see here on the screen: assessment, capacity building, planning, implementation, and evaluation. That's really what guides prevention professionals on implementing both data-driven and evidence-based prevention strategies. And it also has 2 cross-cutting principles, which you can see in the middle: sustainability and cultural competence, that are really integrated across each step. And so the SPIF is pretty much designed to help gather and use data to guide all of our prevention decisions. And so we can see the importance of data and how data is collected and used at each step of the SPIF. So in the assessment phase, this is when we're doing our community assessments and we're collecting data on substance use prevalence, risk and protective factors, and some of that other relevant community information. And then in capacity building, we're using data to build our internal and community capacity to address the issues that we've identified. And we're using that personalized data to start telling our story so that we can engage new partners in our work. And then in planning, we're using data to find evidence-based programs that are going to match our needs. Implementation phase is when we're consistently monitoring our progress and we're reviewing the data so we know if and when to pivot. And then in evaluation, we're actively developing measures and collecting data so we can evaluate our outcomes and also our processes. So besides the fact that it supports strategic planning, there are tons of other benefits of using data in prevention. I'm not going to go through all of these, and these are also not comprehensive. I'm sure there's many more that you can think of, but data helps us assess the prevalence of these health issues and inequities, including helping us address new and emerging substance use trends. This is where data comes up a lot in my work. We do a lot of webinars on emerging trends. Data is needed to secure grant funding or to do your grant reporting or to do fundraising for the work that we do. It's really important to provide data to advocate for that investment in prevention, either at the organizational level, the community level, or maybe like at the policy level with legislators. And it's also what builds our community support and buy-in. If we have the data to show community members that things work, then that's going to be really great. And it also contributes to developing just this wider culture of prevention. We're advancing the science with evidence for these new strategies, programs, or processes to make sure that we're really addressing substance use. So I have a question for all of you. If you want to go ahead and respond in the chat box. What are some of the ways that you would like to use data in your work or ways that you've used data in the past? I'll give everyone just a minute to start typing. Elise says that we use data for assessment purposes, building our community needs profiles, and then evaluating our programs. That's great. Dion says that they would like to use data to better understand root causes. So some of those like community-wide risk and protective factors. We'll talk a little bit about that in our next learning objective. Carrie says to show why prevention plans work or why they're needed. So part of that like investment in prevention piece. And Cody's saying to identify which primary prevention resources would be beneficial for direct services and to identify gaps and barriers to services. I really like the identifying gaps. I think that data can really tell us a lot about that. And Chris is saying grant writing assessment processes and outcome evaluation kind of again goes back to that funding piece, fundraising. Susan says we use data to guide all of our work, including evaluation. Yeah, the evaluation piece is really important. Okay. Oh, and then Sarah says data is used to drive the work that we do. Without data, we cannot prioritize our focus. I think that, Sarah, that perfectly sums up exactly what I'm looking for, right? Data is really something that we're using at every stage, and we truly cannot do our work without data. So I'm going to take us into our next learning objective here. We're going to spend some time talking about the different types of data that are out there and then some different data collection methods. So, there are different types of data that are available to us in prevention, and we want to be really careful about determining our scope before we actually start going out and looking for data. So we want to ask ourselves, right? How are we actually going to be using this data? Are we trying to figure out data for a needs assessment? Are we writing a grant report like Chris had mentioned? Those are going to be two different approaches. They might require different data sets. So it's just really important that we know what it is that we're using our data for. Once we know how the data will be used, then we can kind of decide what data to look for. And so we're going to cover pretty quickly these four broad categories of types of data over the next few slides. So when we're looking for prevalence data, we're really trying to measure the scope of a problem. So we're talking about the magnitude, the severity, any of the trends that you're seeing in a substance use problem. So some of the questions that you might ask yourself would be, what specific substance use trends are occurring? Is it fentanyl, alcohol, youth vaping, whatever's going on in the community? How often are consequences of use, and any related behaviors occurring? So consequences of use could include poisonings, overdoses, DUIs, things like that. And then the related behaviors could be co-occurring mental health illness, academic problems, those types of things. We also want to know where specifically these problems are happening in the community physically, like which neighborhoods, which zip codes, and who's experiencing the problem. So this means the demographics of our population. And this piece is really important for us to measure because we want to know how these prevalence compares across populations, across different racial and ethnic groups, different income levels, sexual gender identities, because this is how we start to begin to identify some disparities. So when we're looking at data for risk and protective factors, we're really trying to answer that question, why is this happening in the community? So you might be discovering, that substance misuse is changing in different ways across different communities. So maybe a particular group has really seen a huge uptick in a certain substance when other groups just haven't. So we want to know, why is this happening? And often there's certain shared risk factors that can increase the likelihood of substance use that data can tell us about. So things like perceptions of harm, levels of parental support, reduced access to healthcare services, lack of economic opportunity. These are all really important factors that have found to be associated with substance use. So it really helps to kind of look at the research and see what it says about our population of focus. If we're looking at substance use within the LGBTQ plus community, there is research that tells us what risk and protective factors have been identified among that group already. So we might be able to use that as a starting point to kind of see if that's being reflected in our own community. So the next is for capacity. And so capacity is really about building up your resources and improving your readiness to address an issue. So once you've kind of identified the substance use problem, the risk and protective factors, you need to know whether you're actually ready to work on it. And so what resources and partnerships you'll need to do it. So some questions that you might want to ask to gather data would be, how many resources do we already have? What are our funding levels? How many trained staff or volunteers do we have? And so once you know that, you can kind of start to identify the gaps in what you need. So then you could ask, how many resources can we obtain and where can we get them from? There's really no work that we could possibly do in prevention alone. So we want to know who's willing to work with us. What partners exist in the community, what are their goals, and how do they support our goals? And then in terms of community readiness, what does the community actually believe about the issue? What are their opinions about the problem and the community's ability to actually solve it? Do they believe there's even a substance use problem at all? Are there any myths that we'd have to dispel about substance use or any stigma that we'll need to address? That's really important data to start gathering before you do your work. And then lastly, maybe you're just a little bit more narrowly focused on doing a program or a process evaluation, as many of you have identified. We're kind of talking about that fifth step 5, but the important thing that I want to note is that even though it comes last, it's really something you want to plan for as early as possible. When you're doing your needs assessment, you should already be thinking about your evaluation, right? So what are the goals, objectives, and outcomes of our program? Something that's, part of your logic model, just really crucial data points on program outcomes. Were they actually achieved? Did the program or the strategy adequately address the needs of our target population? Was it cost effective? Were there any unexpected or negative outcomes from our intervention? And then, of course, how can we improve program implementation and our processes in the future? So on the next 2 slides, we've pulled together a ton of examples of secondary data sources for you. And so secondary data sources are the data sources that already exist out in the world. Someone took time to collect and report this, and then you're just going to pull from that. The example on the side are broadly data about substance use, but they might have some other important risk and protective factors or community information that might be relevant. And so we have it broken out by national, state, and local data sources here. The national data sources, a lot of the data sources that we have on here are the ones that we typically use to talk about the current substance use landscape, like across the field. Something that I always want to note when I talk about this, though, is that national data sources are really slow to update. NISDA didn't start asking about fentanyl until a few years ago. There's very little national vaping data because that's just kind of something that's starting to be asked about. But there are some great national surveys, right? Like the NISDA, the Behavioral Risk Factor Surveillance System, the Youth Risk Behavior Surveillance System, Monitoring the Future, we didn't put on here, but that's a great one. The data that's collected through CDC Wonder or the Drug Abuse Warning Network, which was offline for a while, but is back up now. You should also consider, different trade associations like the Association for Addiction Professionals or American Society of Addiction Medicine, or some of that research that's out there in academic journals. PubMed is a really good place to go for free academic research. And something else that's not on here, but I wanted to mention was, those national nonprofits and like really big think tanks, they often do a lot of data collection and reporting, so they would be great too. There's also state level data sources, a little bit more kind of localized to your needs and your resources potentially. Your state Department of Education has general student surveys, demographics, test scores. State Department of Health has surveys and vital statistics data. Really importantly, they know where the prevention money is and any of the other ongoing prevention efforts in the state. The state DMV could have some of that information on citations or on alcohol or cannabis-related traffic incidents, DUI trends. The state police or state courts can tell us about arrests and convictions that are related to underage alcohol consumption, public intoxication, possession and trafficking, things like that. And then finally, there's also lots of local data sources that you can use, right? So your county medical examiner, they have the data that actually gets fed up to CDC Wonder, but CDC Wonder at this point, I think is like 2 or more years behind. So if you're looking for more recent data, sometimes it's best to go local. And that would include like your local hospitals, urgent care centers, Substance use treatment and recovery providers might have some really good qualitative observations of trends that the providers are seeing, local law enforcement, school districts, colleges and universities, and the like. And so we also wanted to share some data for obtaining information on the social determinants of health when someone had mentioned earlier some of those community factors. We're going to talk a little bit more about the SDOH later in the presentation, but super briefly, these are the social conditions that people experience in the places where they're born, live, work, and age that have a really wide range of effects on different health outcomes. And so we talk a lot about the SDOH in prevention because inequities in the SDOH have really been found to be associated with pretty significant differential outcomes in substance misuse prevalence, severity, and some of those consequences. So when you're thinking about that community context or the risk and protective factors, maybe you might want to take a look at some of these sources here. I'm going to highlight just a few for the sake of time, but as Ruth said in the chat, these slides will be available to you, so please take a look at these later. The Area Deprivation Index, that first one here, this is a mapping tool that sort of displays the relative socioeconomic conditions of different neighborhoods and then ranks them. So comparing levels of income, education, employment, and housing quality. CDC Places, this provides different health data and also health-related social needs like how many people are receiving food stamps, have transportation needs, feel socially isolated, and some of those other things at the county or even at the census tract level. The Child Opportunity Index, this measures and maps the quality of the resources and some of the conditions that are really important for children's healthy development in their neighborhoods. So again, all of these are really important data sources that are available for free to you and help sort of assessing the community context and some of those risk and protective factors related to the social determinants of health that I think can be really helpful for informing some of the work that you're doing in the community. So I want to pop into the chat again, kind of take a moment and ask, what other sources of secondary data have you used before to achieve your prevention goals? Obviously, many, if not all of you, are in Michigan, and I did identify broadly some state or local level sources, but I'd be really curious if there's specific sources that you've used that you think would be helpful for your peers on the call that I didn't already mention. So again, I'll kind of give everyone a moment to start typing in the chat. And if you haven't been able to use any other secondary data sources, are there any data sources that you think you would like to find? Any questions that you have that you think, might be solved with data, and so you'd be curious to ask other folks if they know some data sources for you? Okay, Fatima says informal study groups. Amanda says I mentioned a lot of them. That's great. Lee has put a link in the chat. Really encourage folks to click on that. Chris says forums and interviews. We're going to be talking right after this about data collection methods that should kind of pick up on what some of you guys are talking about. Focus groups and key informant interviews. Okay, Michael's got a great contribution in the chat. Anishinaabe, knowledge of our ancestors, four directions, seven grandfather teachers, culture is prevention. We're going to be spending some time talking about data as it relates to Indigenous populations, and I'm really glad that you brought that up, Michael. Ruth says behavioral health treatment data sets from mental health providers. That's also great. We know that there's like a lot of co-occurring mental illness and substance use. Okay, that's great. I appreciate everybody kind of dropping some stuff in the chat. If you do think of something, I encourage you to still drop it in the chat because it probably will be helpful for somebody who's taking a look at it. So depending on the data that you can obtain from any of those existing data sources, you still might want to collect some data yourself. And so this is our primary data. And it can really measure a lot of the same things that we've already been talking about, right? The prevalence and the scope of the problem, some of the related harmful behaviors, risk and protective factors, capacity, as well as our program and our process evaluations. So we're going to go through 6 different methods of data collection pretty briefly over the next few slides, some of which clearly some folks are already familiar with, which is great. So we'll talk pretty briefly about surveys, key informant interviews, focus groups, environmental scans, asset mapping, and then some other methods worth considering, which I will keep as a mystery until we reach that slide. So the first we have our surveys, right? Some of the advantages of our surveys is that they can be highly accurate, reliable, and valid. And you can really use them as a comparison to other populations. They're obviously used to generate quantitative data, which does tend to be a little bit easier to analyze than qualitative data. And you can add a lot more sensitive questions to surveys than you could in some of these other face-to-face data collection methods. Surveys are intentionally anonymous because they're protecting people's identity. And because people know that, they might answer a little bit more honesty. But there can come with some challenges too, right? The accuracy of your survey is really going to be constrained by the size and the diversity of your sample. So really depending on what your sample looks like, your survey responses can't always be totally generalizable to the wider populations. So you really have to think about, oh, I see actually Ruth just mentioned me that we do have a hand up. I'm so sorry, Anthony, I don't have the pictures open, so I can't see you if you wanted to ask your question.
Actually, no, thank you. I didn't have a question. I just put, I think, my information in the chat.
Okay, great. Yep, your little hand is up in your box, so
Oh,
just
I'm
wanted
sorry.
to make
Then
sure.
let
No,
me.
nothing to be sorry
Okay.
for.
Yeah, I accidentally hit it then. Okay, thank you.
Yeah, not a problem. Just want to make sure we get to everybody, so no worries. So kind of back to talking about our sample. If you are doing a survey, then you have to really kind of consider some of the methods in which you're actually administering the survey. So, is it an online survey? If it is, then you have to really consider that your sample is only people who have access to a computer or to the internet. If it's only available in English, that means that only people who feel like they can actually understand English can answer your survey. So it's just something we really want to be aware of when we're trying to think about who we want to survey and what questions we want to answer, especially if we're noticing trends in communities that might not have access to your survey. You have to be really intentional about providing that access in a culturally competent way. Surveys can also have pretty low response rates. This is especially true the longer the surveys are or the more open-ended questions you have on the survey. And it can be really hard to explore issues in depth. So next we have our key informant interviews, also known as one-on-one interviews. Some advantages are that they tend to be pretty low cost, and to that end, they can have a pretty short turnaround time. And it really allows respondents to define what's important to them. When you're giving someone a survey, you really have no idea if there's one issue that's going to be more important to them than another issue. But in interviews, the respondents can really spend a lot more time on the things that are important to them. And so then related to that, you can explore issues in a much greater depth. The interview respondents can also be sources of leads to other sampling. This is usually called respondent-driven sampling or snowball sampling. And although interviews do often take much longer to complete compared to surveys, they do have lower refusal rates. People do kind of tend to take them a little bit more seriously. And they can be a really good opportunity to build partnerships. In contrast to your surveys, you really can take the time to build rapport here. But of course, there are challenges, right? Having scheduled so many interviews before, they really can be time consuming to schedule. And it does require a skilled interviewer, especially if you're working with vulnerable populations. Your interviewer needs to be trained in a trauma-informed approach. They should definitely feel comfortable with responses that are maybe heavy or controversial, and understand how to communicate with that person so that they feel heard. There's also a lot more limited generalizability because your respondents are speaking about their unique lived experience. Once we start coding and analyzing the data, then we can draw out themes that are a little more generalizable, but even that's just going to be amongst a pretty small group of people. And they might not provide sensitive data. You do have that opportunity to build rapport. So, generally it's recommended to ask some more sensitive questions towards the end of the interview. Don't end on something, potentially very traumatic and upsetting, but kind of wait until you're towards the end, the back half to start answering those questions. And then there's always the potential for interviewer bias, right? Unconscious bias is a part of human nature. It's really, really important that we acknowledge that and we remember that and that we, provide trainings on that when we can. So next we have focus groups. These are similar to interviews, but with more than one person, sometimes more than one interviewer, depending on the size of the group. Their advantages and challenges are very similar to that of interviews, which you can see here on the slide. So I'm not going to spend a ton of time on this, but an advantage that we don't have on here that I want to mention is that in a focus group, the nature of having that roundtable type discussion can really inspire people to think about some things that they might not otherwise think about on a one-on-one interview. Someone might mention their experience with something that could prompt another group member to say, oh my gosh, this reminds me of my experience. And then you really have a deep discussion flowing after that. Of course, there are challenges as well. Notably here, it does offer a little less control over the process. Those group social dynamics can really come into play, and the conversation could get away from you if you're not kind of keeping track of it very carefully. Some people feel totally uncomfortable speaking up when they're in a group, or, if they see that one person that they think is maybe monopolizing the conversation, they might pull back. Some folks feel less comfortable answering sensitive questions because they're in a group, whether that's because they're with strangers and they think that's weird, or they're with their peers and they think that's even weirder, or there could actually be a lot of disagreement and discord within the group. So it does take a skilled interviewer to be able to manage a focus group, but having done many of them before, I really think that focus groups can give you some really good data. So the next we have environmental scans. And so environmental scans are really kind of exactly what they sound like, right? They're an intentional scan of the environment around you. They do sometimes get confused with needs assessments. While a needs assessment can be considered a type of environmental scan, environmental scans are generally more broad than a needs assessment. They're focused a lot more on that big picture rather than some of those little details. They provide a lot of context and some of, identification of the areas that might need a little bit more investigation rather than identifying those specific needs. And they rely on secondary data rather than primary data. Our last couple approaches were primary. These rely on secondary. So environmental scans would include, an analysis of some of the political, economic, social, technological, legal, any of these environmental forces that are happening in the community. It would also include just a review of the literature. So any existing reports, data, gray literature, other publications, including a lot of the secondary data sources that we talked about a few minutes ago. And then it would also include a SOAR analysis. So this is an analysis of community strengths, opportunities, aspirations, and results. So our environmental scans are really useful in identifying, again, kind of what's going on in the environment around us. It can help us identify the causes of health issues, the community or the organizational capacity for addressing the issues that we've identified, any of the barriers that might come up that would hinder our ability to actually address these issues, and then some of the environmental strategies or behavioral strategies that already exist for addressing the issues. So in prevention, we can really use these to help us focus our needs assessment, because once we kind of understand the environment and what's happening around us, then we can focus in on identifying the needs of our population. Can help us guide efforts to develop partnerships because, we're kind of already accessing what resources exist in the community. And then when we review the evidence base in an environmental scan, we can really figure out what interventions might we want to learn more about. And then it can help us kind of with the literature support our implementation and evaluation of these efforts. So then next we have asset mapping. So this is a strengths-based approach. This is really focused on identifying and leveraging the existing resources in a community. So while our needs assessment is kind of focused on exactly that, what our community needs, asset mapping focuses on what a community already has. So this is commonly visualized through GIS or spatial mapping. So as you'll see on the next slide, asset maps are usually literally maps, but they can also be a diagram that kind of organizes resources into different buckets. There's a lot of different ways that you can do it. But asset mapping can be really useful in prevention because it's giving us information on our community strengths, resources, the physical structures and spaces, the people that are in the community, both the residents as well as our power brokers or our trusted community leaders, local cultures and traditions, institutions, local economy, so many more. And all of these things are really, really important for us to know when we're doing work in the community. So as you can see here, not super clearly, I apologize because we don't have a ton of room, but we do have some slightly blurry examples of asset maps on this slide. And so in each of the maps, the focus community is kind of highlighted in yellow. So you can see the boundaries and you can see the roads and the buildings. And so they each will come with a key where there's just like little dots on the map that indicate the information that we just talked about on the previous slide, right? So where the church is, the liquor stores, the schools, community centers, anything that the community has. So this is really just a great visual tool to see what's going on in the community and really kind of help you gain a deeper understanding of some of the resources, the culture, relationship, power, and structures that are happening in the community. So they can help us really make some important priorities for our planning. We can use them as a tool for conducting needs assessments because kind of a secondary outcome of this would be seeing the areas where there aren't any community resources too, right? And then a few more advantages here on the screen that I won't get into, but yeah, they're a really great tool for doing some community work. So then lastly, our mysterious other methods that we have. And what we mean by this is that we want to take the time to remind folks that you should always consider other non-traditional methods of data collection when you're working with some populations, especially those that have their own traditions for sharing information, in particular with Native American or Indigenous communities. We'll be talking about this more towards the end of the presentation, but it's just really important to consider the fact, like I said at the beginning, everything is data. Storytelling, talking circles, and visual expressions are all very important ways to collect data that prioritize the safety, well-being, and self-determination of Indigenous people. For other groups, youth being a great example, visual expressions can also be a really great method of data collection, whether that's through painting or drawing or poetry or music. Photo voice, which is a really cool strategy where you give someone a camera and then you tell them to just go out and take pictures in the community. And so that really gives you some great insight into, how people see issues impacting their community. So again, just, be sure to remember that there are non-traditional methods of data collection that are just as important and just as valuable to our work. So now that we've kind of talked about the how of data collection, let's talk about some of the challenges that might come up as you're gathering or analyzing data, and then some of the strategies to help address them. So first, I kind of want to pause again and hear from all of you. Before I get into the challenges I've identified, I'd really like to know, what challenges have you encountered? What challenges have you been working through with data? So again, I'll give folks a minute to start typing in the chat. Fatima says biases. Definitely. I could definitely see that. The basics of just getting people to answer the surveys, especially around program-specific data. That can be very true, especially if you have programs or grants or whatever where you can't necessarily provide incentives. That's usually what we recommend in like academic research is incentives, but I know there's some rules around that. Cody says not a ton of data readily available on Native American populations. There's a lot of reasons for that, and that's something that we will get into later on in the presentation as well. Susan says getting the same schools to take the MIPHY. Michigan, I don't know what the rest of those letters are. If you could either come off mute and share that or say it in the chat.
All right, it's the Michigan Profile for Healthy Youth. It's
Okay.
a Michigan survey for schools.
Okay, perfect. Yeah. So, making sure that the schools actually invest in taking the time and, whatever they need to do to actually do that survey. Ruth saying people unwilling to share sensitive data around fatalities, medical examiners, and county clerks. Vicky says our youth do not believe the data. They think the percentage of 30-day use rates are higher than what survey results show. That's interesting. That's kind of like the perceptions of peer use. Sarah says county leadership is not willing to allow certain questions to be asked. I'm sure that has definitely become an issue for some folks in different political landscapes for sure. And Barbara says conflicting and or inconsistent information. That can definitely happen if you're getting data from multiple different places, and that can be really frustrating to have to deal with as well. Chris says most data is county when it needs to be more local or rural. Rural data collection is definitely something that's not my area of expertise, but I do understand that is a huge problem that some folks run into when you're working in more rural communities. Okay, these are really quite comprehensive. I think you might see some of the ones that you've mentioned in here, but I've got a ton of other challenges that we might want to consider, when we're talking about data. So the data might be aggregated, which, is really when multiple data sources combine individual level data, which is then kind of averaged to provide a high level overview of a larger group. So, if you're getting data from a hospital system that's showing the number of visits to all of their emergency departments over a 3-month period, There's obviously probably an important use case for this, but this is aggregated data and there are problems with that. If you're only seeking information about youth who went to the hospital in your town, this is frustrating because you might not be able to get that. So that aggregated data really just eliminates individual level characteristics, which can also impact our ability to recognize the presence of disparities. If we see that, X number of residents in the state who needed treatment got it, we might think, oh, this is so great. But it doesn't tell us enough information. Maybe the individual level data reveals that only 10% of a certain group of people in the state received treatment. So that would be kind of indicating a huge gap in services. You might also find that your data is just missing or incomplete. Maybe you're missing a month of observations, or only 20% of your data has gender. You can't really draw any conclusions from data that's incomplete. And if you have a lot of missing data, then it might not really provide that accurate picture of the community. And this is especially true if some information is consistently missing, right? Like records from a particular school or a police precinct. You also might look into the methodology and see that the data that was collected in ways that don't really match your needs. So maybe the questions were poorly worded. Maybe the catchment area doesn't match your project needs, which means that, like Chris kind of mentioned, maybe you need county level data or like very local level data, but all you can find is state level data. That's very frustrating. Some of these jurisdictions might also overlap too, right? So the boundary of your police department might not be the same as the school district, and that could be a problem. It's possible your data might be collected in time periods that were just inconsistent or too short. One thing that we've seen before is data from one agency is organized by calendar year, another by fiscal year, and then another by school year, which is very confusing. Or your data just might not be current enough or, collected for a long enough time to really be able to track those trends accurately. And a big problem that I think a lot of people face too is that it's just really hard to assess, collect, and use data without sufficient prevention resources and infrastructure, which kind of goes back to that need, for always building and sustaining capacity. So some additional challenges that we see with data, there might be gatekeepers of data who are not willing or just not allowed to share data. So for example, different medical professions might sometimes actually be restricted from sharing data. They might have worry over, violating certain regulations around patient privacy or HIPAA laws. Maybe the data is made available to you, but it's really difficult to access. Maybe there's some really frustrating database systems that I think many of us may have had to use before that are just not user-friendly, or somebody is just taking you forever to get that login information to be able to get in. Again, you might receive some data that's not in readily usable forms, so too aggregated or overlapping. Maybe some of your variables have different definitions from your other obtained data. I've seen some research studies where they acknowledge in their limitations that the surveys that they used, some of them defined binge drinking in one way, and then some of them defined it in another, which is going to kind of cause some problems in your data analysis. Maybe the data that is available to you actually isn't really relevant to your current needs. So, for example, overdose data wouldn't really be super helpful if you were trying to determine marijuana prevalence, but that might just not be something that's relevant or available to you. And it's also possible that you would receive outdated data or data that's been accompanied by a really misleading or maybe incorrect analysis. So maybe the data is being held by a person or a group who isn't really familiar with statistical techniques. So you might have to try and get those raw numbers and rerun it yourself. A lot of times that we find that there's really a lack of any data other than prevalence data, which is obviously really important, but it's not really telling the full picture of the substance use problems that are happening in the community. Or sometimes there's just a lack of expertise at reviewing academic research. This can be a really challenge. You don't necessarily need to be a statistician to like read and understand an academic article by any means, but it is really important to have like a foundational understanding of what some of those numbers and what some of that statistical analysis means. So that, the research was like reliable, valid, and all good to go, but also so that you know what it is that you need from maybe a more confusing study that's specifically applicable to your needs. And then we also have identified some data challenges that are specifically related to equity. Maybe there's just a lack of existing data for all the populations that you're trying to serve. Someone had mentioned this in the chat as well. It can really be a challenge to find that existing local level data, let alone data that's specific to each of the populations in your community that do, need prevention services. In a lot of cases, these data just don't exist. And if they do exist, sometimes they're in really small numbers, which can make your data analysis and interpretation actually quite difficult. Obviously, there may be cultural or language barriers in some data collection tools. There's the problem of not just having the direct translation available for all the languages that are represented in the community, but also that cultural context might just be missing with the translation that leads to maybe confusion for native speakers who are reading a translation that doesn't really take that into account, which is not only offensive to them, but can also significantly, derail your data. And there might be cultural traditions around data collection and surveying and all of those things that we have to account for, like we kind of talked about a little bit ago. Some communities have been traumatized by federal data collection efforts in the past and, are maybe unwilling to participate. And we have to kind of acknowledge and sit with that. There might also be demographic response options that aren't really reflecting the cultural identity groups that are present in your community. Demographic options that we do have on our surveys should really be revisited as the population changes. A great example of this that we had found was that the Minnesota student survey added Hmong and Somali response options a few years ago. They added new questions about gender identity to really make sure that they were reflecting the changing community. So we always need to consider, how is identity being determined and collected? In some of our communities, law enforcement, medical examiners, whomever, are determining race or ethnicity to the best of their abilities rather than actually relying on self or family report, which is obviously not good and has a huge potential for bias and just, total inaccuracies. And then there's also challenges that arise when you work in homogenous populations. While there's lots of factors that can influence health and access to services, race and ethnicity does tend to be a little bit easier to assess. But even within a racially homogenous population, there will be significant variations in socioeconomic status, sexual orientation, education that are all really important. Also, the composition of our communities might change throughout the year. In some areas, you might see seasonal changes, people moving north in the summer, south in the winter. You might see a large population increase in the fall when college students come to campus. So, community might genuinely look different at different points in the year. And so if we assume that, a college town is homogenous and that most of our residents are like under the age of 30 all the time, because that's when we collected our data, we would seriously miss a lot of populations who might need prevention services that fall outside that age group. So given all of what I've just shared, everything you guys have shared in the chat, we do want to present a couple of ways that we've identified to address some data challenges. So obviously this is not comprehensive. It isn't responsive to all of the data challenges you might encounter, but these are just some tips and best practices to try and help alleviate some of that potential strain. So the first is to identify which data sources might be available for you, and then whether there's any overlapping sources if you turn out to be unavailable. So, if you're looking for data on vaping, don't just commit to one source and say, well, that's all I've got. See who else has data on vaping. Understand that there might be differences between the data for a lot of different reasons, differences in population weighting estimates, data collection methodologies, all of those things, but always find your backups. It always helps to have a super clear data request. Explain not only what you're looking for, but also what you don't need. For example, if you don't need some of that individualized data, some of those HIPAA concerns that we talked about might not actually be relevant, which could actually speed up your data request. So it really helps if you can work as closely as you can with your data sources to figure out, they might have other data that might better suit your needs. See if you can request data as part of a broader collaboration effort. Sometimes our data gatekeepers, for reasons I probably won't ever be able to understand, see your data request as you just asking for a favor or something that might be a little inconvenient for them. But we know that it's really, really important of our work in prevention. So, describing and framing it as part of this collaborative effort to address a public health issue in the community maybe gives you a chance of having, people see the value in it more. It's also really great to kind of understand some of those relevant regulations and statutes around data sharing and know what data can and can't be shared. Having that knowledge yourself means that you're not relying on someone else to know what the rules are, because honestly, they might not. And so it can really help you kind of work around some of those limitations. And then also it can help you kind of alleviate their possible concerns when they think that data sharing isn't allowed, but you know that it actually is. One of my most important points that I always say is to value qualitative data. Qualitative data is often a lot more readily available than quantitative data, especially at the local level. because even though it's a little bit harder to analyze, it is a lot easier to collect. And it just provides that really useful background and context for the substance use issues facing a community. And it tells that human story, kind of what I talked about at the top of this presentation. We have to continuously remind ourselves that data points represent real people's experiences and lives. And so, qualitative data can help us personalize that and make sure that we're not forgetting to put that human face on the issues that we're trying to address. You can also contact local experts and researchers, work with some existing work groups, local graduate students, outside experts, whomever, not as a last resort when you're kind of hitting a data, wall, but develop those collaborative relationships early on. For many folks here, I'm sure, data collection is overwhelming. Even when I'm doing like the simplest form of data collection, like a literature review, I'm like, wow, this is a lot of work. And because, you're trying to do this as that collaborative effort, there's probably a lot more people who are invested in your success than you think. I think graduate students are great resources because I recently was one a few years ago myself. And they're really looking for those learning opportunities, projects to put on their CV or resume. And they're really already actively using those skills right now as a research assistant or as a student, often under the supervision of an academic who could have some really specialized knowledge that might be relevant to you. And then it's also really important when you're collecting your own data to just consider some of those more feasible data collection efforts. We talked a little bit about the advantages and challenges of a few methods, but if you're a small group with limited time and resources, you should be using those interviews or focus groups instead of designing a really large, elaborate survey as your form of primary data collection. You can still extrapolate some quantitative data from qualitative methods. It just takes a lot of the strain off of you. And then also be willing to refocus your primary data collection efforts if you need to. If there's like existing prevalence data already available, you don't need to reinvent the wheel and you don't need to duplicate that effort. Instead, focus your questions on some of the relevant risk and protective factors or the capacity or some of the other things that would be useful. And so for just a few more suggestions, first, it can really help to reframe your assessment questions if you're finding that they're really just not giving you the data that you need. Like we've been saying, be willing to pivot, make some of these changes, it'll be okay. Try and collect and integrate data across multiple different types. So anecdotal data, observational, qualitative, quantitative, they're all really important because together that's what gives us the fuller and more comprehensive picture of what it is that's going on. And that can also help you potentially address any gaps in data from one set with, observations from another. Really importantly, try to anticipate the partnerships that you'll need with other sectors to kind of standardize your data collection approaches and make sure you're obtaining that data more quickly. If you decide that you are going to need data from the sheriff's office, I can tell you from direct experience from a project that I worked on, if you don't have that relationship with them already, you might be waiting a very long time to receive your data files. You might not hear back when you try to schedule an interview. So again, it's really important. It always comes back to capacity. Really try and think about as early as possible, who has the data that I might need and how can I engage with them? And then lastly, it's really critical to always try and build towards culturally appropriate data practices. Unfortunately, there is something that's happened for, many years that is called helicopter research. And so it's where a researcher comes into a community, collects the data they need, and then they leave. The community never receives the results. The data are never used to improve community health, which leads to a lot of distrust of any sort of data collection. So it's really important to kind of consider and think, has this occurred in the past before you begin working with a community? So, we always want to try and build towards addressing ethics and equity in our work, but, especially when it comes to data, which I have to say myself is a pretty good transition into our very last learning objective, which is all about promoting data ethics and data equity. So why is all of this important? Ethics really guide a lot of what we do as preventionists, both in theory and in practice, right? It helps us recognize our responsibilities to the public, to our clients and communities, and to our colleagues that are in and outside of the field. I know that prevention has to abide by a code of ethics for prevention specialists that emphasizes the principles of non-discrimination, competency, integrity, doing no harm, maintaining confidentiality, and also being proactive on, public policy and legislative issues. And this is true for folks who aren't prevention specialists, but work closely with prevention, right? I am not a certified prevention specialist, but I am a licensed social worker. And so I'm bound by the National Association of Social Workers Code of Ethics in order to maintain my license, right? And I have to do my work effectively and ethically. Those ethical principles really do guide the work that I do, even as a macro level social worker, researcher, TTA provider. So one of these major ethical considerations in prevention really should be applying some like significant standards to data collection to promote equity and minimize harm. The only piece about data in the Code of Ethics for Prevention Specialists is about making sure to keep data confidential. But there is a lot more that we should really consider about this. But why do we actually need the ethics? Well, it kind of seems obvious, but for a long time, data was not collected with ethics in mind. The example that I put in here is the Tuskegee syphilis experiment, which is a very famous example of unethical research practices. Researchers didn't obtain informed consent, didn't make treatment available, among many other horrible things. This experiment in particular did actually lead to a lot of really important changes in research ethics, which is great, but it did a significant amount of physical and psychological harm, both to the people who were actually involved in it and to an entire generation of people who were affected by it. So if we're collecting data on marginalized or underserved populations without maintaining absolutely high ethical standards, we can start to exacerbate those researcher participant power dynamics that already exist and really further perpetuate harm and inequity. And, with the emergence of AI and some of these other types of technology that's reached kind of a very weird point in our society where we're really starting to use it a lot without having actually done a lot of research on the implications of using it and what happens with all of that data that's out there, I think that ethics are important more now than ever. So when we prioritize ethics and data collection, we're protecting people's privacy. We're avoiding potential misuse of data that can actively harm people. We're building trust in communities that we're using data for the right reasons. We're ensuring equity, and we're always upholding accountability, both to ourselves and to the field of public health at large. So after many various unethical research societies, we finally kind of started to get it together as a society in like the latter half of the 20th century, and we really did start to prioritize data ethics. If you have any sort of formal research background, you're probably familiar with the Belmont Report. This was kind of like a first of its kind report from 1979 that issued guidelines for protecting human subjects in research that was supported by the federal government. And so we still follow some of those principles today and have added additional principles to really support people. So broadly, some of the principles of data ethics at large are, respecting privacy and confidentiality, making sure that we're establishing measures to protect privacy at every single stage of data collection, analysis, and dissemination. Promoting fairness, inclusiveness, and justice, which means that we're ensuring that data are collected fairly, that they represent all audiences, that we're working towards removing biases from data and data processing, adopting practices that ensure inclusivity and equity, like open communication and collaboration with our stakeholders, and then ensuring that there's really a fairness in the distribution of benefits and burdens from research, right? So not one group gets all the benefits from research and another group bears every single burden. Ensuring transparency and accountability. This is meaning that, we're fostering a culture of responsible data processes at our organization and, that there's really set responsibilities and pretty significant oversight into the data collection and maintenance that we're doing. That we use data to increase our own accountability to the community and to the field, and that we're really being transparent about how our data are being collected, processed, and used, and that data are being used in the ways for which we've actually intended them to. Another principle is also, maintaining accuracy and integrity, which means that we're really ensuring the data we collect is accurate and reliable, and that it was collected and analyzed using really scientifically sound methods. And it also means that organizations shouldn't really be using incomplete or inaccurate data sets, and we should always be reviewing and verifying, the integrity of our own data, meaning that it's complete, consistent, and valid. And then finally, prioritizing beneficence and non-maleficence. This is the part where we're really saying do no harm, securing the well-being of people, make sure that we're minimizing risk and maximizing benefits wherever possible, and that the work that we do is really contributing to the development of ethical practices and policies at large, not just within the research, but across communities and like the wider society. So in all of this work, as we always make sure that we're prioritizing ethics at the forefront, then we can kind of start working towards data equity. In prevention, as we've been talking about, data are used to kind of assess needs, right? And so how data are analyzed and reported has significant impacts on how some populations are represented in research how they're affected by policy decisions, and then the ways in which, resources are distributed to actually address their needs. And so we talked a little bit earlier about, some of those problems with missing or aggregated data. And outside of it just not giving us all the information that we need, it can actually be considered a form of structural racism because, data omissions can really contribute to systemic problems like inability for people to advocate, a lack of resources, significant limitations on political power and political systems. So data equity is just this really intentional process of gathering and sharing data that is inclusive, actionable, and accessible in ways that are really sure to consider and address inequities at every level. So we're recognizing the impact of bias, power, and discrimination, and realizing that it not just, affects people's daily lives, but data collection too. So maintaining equity when we're collecting, analyzing, even visualizing and reporting data can really improve equity in our communities more broadly. So I have some ways that I have come up with for improving data equity that I want to talk about. But first, for our last audience question for today, I would like to hear from all of you. Can you think of some ways that you've tried to improve data equity in your work? Or if you haven't had the chance to improve it, can you think of things that maybe you would like to do? Because I know that this is an issue that really does affect all of us. Fatima says increase diversity. Ruth says including the MENA, yes, and state level data collection. Lee says testing questions and asking if the questions are accessible to different groups. That's definitely something that I will mention later. That's perfect. Yeah. Um, Excellent. All right, so I'll go ahead and move forward for the sake of time, but if you do think of additional things, drop them in there. I want to make sure that we have enough time for us to have a pretty ample Q&A. I will say one more thing from Chris, aggregated online needs assessment survey with personal interviews. So do you kind of mean that you're using the personal interviews to supplement some of that information? Yes. Okay. Yeah, that's great too. Because again, you're kind of like giving that like face to what's going on there. I love a mixed methods approach. You probably need more resources to do it, but I think it's really comprehensive. Okay, great. So let's go ahead and move on. And so we'll talk about this amazing CDC resource about data equity and kind of, how it improves health equity at large. And so there's these 5 steps. Steps probably isn't the right word because it's not chronological, but 5 different stages, I guess, that are from that resource. And so we'll talk about what each one of them means. We'll kind of talk about a little bit about how it relates to prevention, starting with recognizing and accounting for systemic factors in data collection. So the way that we can conceptualize this is through the social determinants of health. I told you earlier we'd be talking about it later, so surprise, here it is. So we know the social determinants of health can really just be thought of as another framework for organizing and thinking about community and society level risk factors, and that they do have, a very significant impact on health equity. So if we're keeping the SDOH at the forefront when we're collecting data, then we can really better identifying which issues are occurring in the community, where and to whom, and whether any of those differences in the data that we find are rooted in historical or current systemic inequities. Because a problem that data equity really seeks to solve is making sure that we're not attributing individual blame or choices for outcomes in the data. So when we're collecting data on substance use, it's really important that we try and collect that SDOH data in parallel and kind of compare them and see what's really going on. So for each of these five that we'll talk about, I've pulled in some of the CDC recommendations. And so for this one, it's first to acknowledge these systems, policies, and practices that have led to historical inequities and influence links to health outcomes. Just because it's in the past does not mean that it's in the past, right? Many of these inequities that we've seen, practices like redlining, things like that, have reverberations that are still being felt today through those SDOH inequities and impact the way that we collect data. Kind of going back to the rural thing that we've been talking about. If someone lives in an area that's inaccessible from public transportation, they might not be able to reach our services. And so we aren't able to gather data on that. So if we're using the SDOH and we're kind of thinking about transportation needs of our population up front, and we can try to work those, transportation into our services, that improves our data collection. It gives us a more accurate scope of who's actually being represented in the data and how our community members interact with our services. And importantly, who isn't interacting with the services. And then second, consult with local community members to identify the relevant social, political, and economic factors that can shape how health outcomes are measured and reported. We don't need to assume these things, and we absolutely should not. There are trusted community experts who can help us with this, which I'll talk about a little bit more in the next few slides. But the community member will be able to tell you this data that you're seeing that indicates X community is doing Y behavior because of Z reasons. Here's what's really going on. So the second point here is to use equity-mindedness for language and action in our data collection. And we can do this as preventionists by utilizing a cultural humility mindset. Cultural humility is something that we could dedicate an entire 90 minutes to. I have before, but since we don't have time for that, I'm going to speak about it pretty briefly here. So cultural humility is really an ongoing process of self-exploration as well as self-critique, combined with a willingness to learn from others, honoring others' beliefs, customs, and values, and then acknowledging and accepting those differences. This can kind of be seen like a step further than cultural competence, right? Because it kind of argues that you're never fully competent in a culture. You can never really know everything there is to know. It is an ongoing, lifelong process of learning. So there's 3 tenets of cultural humility, which I have here on the screen, which I will cover super briefly. The first tenet is that lifelong commitment to self-reflection. Learning about other cultures starts with really discovering more about your own, including that examination of your own beliefs and identities. So cultural humility mindset really calls on us to acknowledge and respond to our implicit biases through this ongoing commitment to self-reflection about our positionality in the world. So our positionality would be like our gender identity, race, physical ability, religion, all of those types of things, and seeing our differences from others as areas and opportunities for learning. Second tenet is to actively seek to address power imbalances. This means that part of our role in prevention is really to acknowledge the existence of the historical institutional inequities and discrimination that we talked about in the last slide, and do our part to dismantle those oppressive systems to promote health equity. And then finally, the third tenet is, developing these non-paternalistic, mutually beneficial partnerships with communities. We should always, always, always see the communities as experts of their own lived experience. And any work that's done in a community can and should not be done without truly equitable partnerships. That famous phrase that we all know, nothing about us without us. A non-paternalistic relationship is one that's going to uplift members of the community to share their experiences and their knowledge about what would be the most effective in, addressing these issues related to substance use, in, data collection methods and all of these things. So cultural humility is really imploring us to acknowledge the inherent power dynamics that might exist and actually take a moment to relinquish power and embrace power sharing and equitable partnerships. So we can see how this is part of our data equity too, right? By discontinuing exclusionary practices, such as using racially or culturally standardized reference categories across data analyses, instead, we let the communities define themselves. Engage diverse data practitioners and communities when developing new practices related to data cleaning, coding, analysis, synthesis, dissemination. This is where that power sharing piece comes into play, giving up some of that power to create partnerships with communities where you both benefit from the work. And then lastly, provide clear language, goals, and measurements in user-friendly formats. By doing that self-reflection, ongoing learning, and speaking with community members about the language and the systems that make things accessible to them, we can start to improve our data equity. And for further community involvement, our third, little point here is allowing for cultural modification of data collection through community-based participatory research, or CBPR. This is a concept that might be newer to some folks. I've engaged in a few CBPR research projects in the past, and they are absolutely incredible. CBPR, very briefly, this is like, a huge topic, but it's a collaborative research approach that prioritizes not just the community participating in research, but community ownership in research planning, data collection, analysis, and reporting. So it really supports the cultural humility mindset because it's really disrupting what we tend to think of as that typical researcher community member, power dynamic. And it really supports uplifting community members as true partners in the research, giving as much weight to their decisions and insight as, our so-called professionals, right? So this approach really lets the community decide what issues are important to investigate, the best ways to collect data in a culturally responsive way, and then how that data can be interpreted in and applied to the context of the community. This is really key. CBPR approach really encourages things like, compensation to community members as a form of reparations. And encourages things like data walks so that every single person in the community, even those who weren't involved in the research process itself, can fully understand the data and what it means for them, which can really encourage community buy-in for your work and really helps with sustainability. Unlike our helicopter researcher example that we talked about, the CBPR approach really gives communities ownership over the process, which means that it's more likely that they're going to continue those efforts in the future. So our CDC recommendations, engage communities when developing new data collection tools or adding modules to programmatic and disease-specific surveillance systems. Someone mentioned this in the chat. I can't remember who. Oh, it was Lee, doing a focus group about your focus group questions, right? This is in and of itself a very useful way to support cultural modification and make sure that your language and your processes are culturally responsive. Assess currently implemented programmatic and disease-specific surveillance systems for opportunities to proactively engage community members. Take a look at the data you do have and see where you can tap into the community to own a piece of that work. And then use data and community engagement to prioritize what issues are addressed and what questions are asked in developing the research plan. I know that sometimes we're a little bit path dependent when it comes to grant funding. If we have a grant that's about youth alcohol use, you have to maintain that focus, but doing that community engagement piece can really uncover so many other spaces where we can really develop a plan that's truly meeting community needs and addressing their priority issues as they see them. So the next one we have is, creating shared data agreements by supporting data governance. So data sharing agreements are something that I highly encourage to folks to look into if they're not familiar. They can be a really, really important tool for when you're seeking to obtain data from another agency. So a data sharing agreement outlines specifically which data will be shared, how the data can be used, among lots of other things. And this is super important in terms of preventing data misuse and confidentiality, which, if you remember, those were two of those key ethical principles that I mentioned earlier. So data governance is really a system of decision points and accountability for data-related processes, right? So we're describing who can do what with what information, when, under what circumstances, using what methods, basically actively implementing these policies for the effective use of data, both at the organizational level, but then also between parties. I will admit this is kind of more of an in the weeds topic, but it's really, really important to bring up because it is, again, part of that capacity piece. I feel like everything always comes back to capacity. If we're supporting data governance within the organization, we're maintaining data share agreements with other groups, you're ensuring that at the organizational level, that this is an institutional priority of your agency, that your data and your partner's data remains high quality, compliant, and secure. And that's really important in terms of ethics. So our CDC recommendations are really, again, kind of about getting the community involved in this work. Seek input from entities who have direct contact with or are led by members of affected populations on the most appropriate issues to consider when collecting, analyzing, and sharing community level data. Engage in project development processes that are more inclusive of the subject population. And then finally, embed communities and data governance structures to elevate community voices and create balanced power structures. Maybe you decide, you want to set up like a data governance committee. That would be really awesome. So if you did, you really want to make sure that you get community members on that committee to kind of ensure that they have a say in the way that their community's data is being used and shared. And then finally, on a related note to that, the pinnacle of data equity in my mind is this concept of data sovereignty. And so data sovereignty is about a group's right to control and maintain their own data about their people, their land, and their cultures. And this being a right is a very, very key word here. This is obviously a huge priority for folks who are working with Indigenous or tribal communities, and something in prevention that I think we really, really should focus more on. Data sovereignty is so, so important in Indigenous communities because it really allows for them to maintain autonomy and self-determination in the face of centuries of historical trauma and oppression. So Indigenous data sovereignty really allows for Indigenous people directly to benefit from the data that's being collected and have the agency to make decisions over how they're represented in the data and how it's being used. This is directly promoting data equity because it is truly giving ownership back to communities. It's also highly culturally responsive because, Indigenous data sovereignty allows for communities to use some of those non-traditional data collection methods that I talked about earlier in the presentation, like storytelling, paintings, weaving, dances, and ensure that this data is interpreted with both the cultural context and Indigenous customs in mind, which can kind of leave out the chance that the data would be misinterpreted, and that communities would miss out on really, really important resources and being denied of further political power. So the CDC recommends ensuring current data collected across your agency from communities accurately reflects the community's values and priorities. Truly trying to decolonize data, I think would be a very long process for anyone, but I really do think that this is kind of the truest form of data equity that we have. And as new data collection surveillance systems are developed among tribal communities, these communities should be consulted, engaged, and asked to guide us through the data life cycle. And so to kind of round out our webinar today, I do want to take another moment to talk about some of these really important principles of Indigenous data sovereignty, because I think this is such an important thing for us to be talking about, really as the field of public health at large, and not something that we see discussed too much in prevention. And it's something you want to work towards in your community. I have two different models here. One on the screen right now and one that'll pop up in a second. So these principles can hopefully get you thinking about some of those important considerations that should be made when you're working with Indigenous data. And also just about our responsibility as prevention professionals in promoting data equity and accountability. So the first one is the CARE principles for Indigenous data governance, which, each of the letters in CARE stands for a principle. So the first is collective benefit. So data systems should be designed and function in ways that enable Indigenous peoples to actually derive benefit from the data and see that the data actually brings forth systemic political power and resources. The second is the authority to control. So Indigenous people's rights and interests in their data should be recognized, and they should be empowered in their authority to control data. This kind of goes back to that data governance piece, because really enabling Indigenous peoples to determine how their people, as well as their lands, resources, and knowledge are accurately represented within the data in the cultural context. Third is responsibility. Working with Indigenous data, we have a responsibility to share how those data are used to support Indigenous people's self-determination and collective benefit. So this also comes down to that idea of accountability. And then lastly is ethics. Indigenous people's rights and well-being should be the primary concern at every single stage of the data life cycle. And then there's also these OCAP principles. This comes specifically from First Nations Peoples Information Government Center in Canada. OCAP also each stands for one letter. So the first one's ownership, meaning that a community or a group collectively own their cultural knowledge, data, and information in just the same way that an individual would own their own personal information. The second is control, which is, basically affirming that it is a right for First Nations people to seek control over every aspect of research and data management processes that directly affect them. And then the third is access, which means that First Nations peoples must have access to data about themselves and their communities, regardless of where the data is actually held, so that they can collectively make decisions about who has access to collective information. And then the fourth is possession, which kind of sounds like ownership, but is distinctly different. Possession is the physical control over the data, meaning that data should be housed on tribal lands whenever possible. So, while there are some similarities between these two frameworks, they are different. I think both can be really important when we consider trying to fully integrate that data equity into our work. For folks who are working with Indigenous communities, and maybe even more aspirationally, something that we can kind of try to strive for as our ultimate goal for all marginalized peoples to own and benefit from their own data. So unfortunately, we've reached the end of our time together. It flew by really fast. I do want to take a moment and kind of wrap everything up that we've covered today before we get into some time for Q&A. But we know, or at least I hope we know after having attended this webinar, that data is a really, really integral part of our work in prevention and the strategic planning process. And it's really crucial for helping the field grow and learn and contributing to the development of just a larger culture of prevention. There's many different ways to collect data to kind of learn more about your community's needs. So be sure to consider what data might best meet their needs and yours. While there's a lot of challenges around data collection, make sure to kind of consider some of those opportunities that we discussed to address them early on. And we should always be collecting, analyzing, interpreting, and disseminating data with those principles of ethics and data equity in mind, particularly when our data concerns members of historically or currently marginalized groups. So that's all that I have for all of you today. I've really enjoyed this conversation. I really want to thank Ruth and Effie and just the Prevention Network for having me. I'm going to turn it over to you, Ruth, to talk about the evaluation if you'd like, and then whatever time is left, we can devote to questions that folks may have. So, Ruth?
Thank you so much, Olivia. The team at Carter Valley Associates has done phenomenal work, and I really appreciate you being able and willing to take time to share it with us. There's a QR code on everybody's screen. There's a link in the chat box. We're asking for your feedback and your evaluation of this session as we continue to strive to provide top quality training, technical assistance, resources, support to our friends across Michigan doing SUD prevention. As we're taking a look at this, please go ahead and put your questions in the chat box. If you're more comfortable with raising your hand and coming off mute, that's okay too. Just a couple follow-up notes. We will be posting this recorded webinar after we've edited a little bit on our YouTube page. So if you haven't checked out our Prevention Network channel, please take a look at that. We have a coalition support channel on our YouTube page, as well as the additional resources that we mentioned. So Lee included a link to the SUDDR, the Substance Use Disorder Data Repository that we use in Michigan. Our friends at Wayne State University School of Social Work evaluation team has worked tirelessly to update that. And so it is a compilation made to for us in Michigan to be able to use those national, state, and local resources. They're continuing to update that on a regular basis. They're adding a resource page with links to videos like this and others that we've created in cooperation with our friends at Wayne State. So if you have questions at this point, we'll turn it over to you all. Thanks.
Thanks, Ruth. Yeah, we've got 10 minutes, so if folks have questions, I'd love to try and answer them. If not, my contact information is also on the screen, so please, write down my email if you think of something later that you'd like to ask. That's totally fine too. So I'll go ahead and pause for a couple minutes and see if folks have questions.